My name is Leslie Playa, and I am the Executive Director of Safe Project. Welcome to our Prevention Month webinar series. Today's presentation is Youth Prevention Transformed by a Paradigm Shift with Sydney Scheifetz and Rana Yablonsky. Following today's webinar, you will receive an email with a link to the recording. Although this presentation does not qualify for continuing education credit, attendance certificates will be sent out in the next 2 weeks for those that attended the live webinar. During the presentation, we ask that you provide your responses to reflection questions in the chat, while any questions you have should be submitted in the Q&A section. And again, a reminder, when you are submitting in the chat, make sure that you're sending it to everyone instead of just hosts and panelists. Before we get started, a little about Safe Project, followed by the bios of our presenters. Safe Project is a national 501c3 nonprofit committed to overcoming the addiction epidemic in the United States. Established in 2017 by Admiral James and Mary Winnefeld after the tragic loss of their 19-year-old son, Jonathan, due to an opioid overdose, Safe Project aims to save lives impacted by substance use and mental health challenges through overdose prevention and response, education on stigma, and development of prevention and recovery programs. Safe Project also provides tailored guidance and training within its 4 key initiatives: safe campuses, safe communities, safe workplaces, and safe veterans. To learn more, please visit safeproject.us. Now on to our presenters and their bios. Sydney Scheifetz is the Assistant Director of Safe Campuses and brings 9 years of experience in international public health, collegiate recovery, health education, and disease prevention to the field. In her current role, Sydney builds and oversees Safe Project's student development programs, working to create learning, advocacy, and leadership opportunities for students nationwide, rooted in health equity, empowerment, and public health principles. Prior to joining Safe Project in 2022, Sydney led prevention, harm reduction, and recovery programs at Gonzaga University. Additionally, she served in the field of global health and education in Brazil and on the polio eradication initiative in Nigeria, where she used public health research to control the spread of infectious disease. Sydney holds a Master of Public Health from Oregon State University and is certified in motivational interviewing, recovery coaching, and ethical public health research. In August 2021, Rana Yablonsky joined Safe Project with 2 decades of experience and reputation as a respected leader in the areas of youth substance use prevention and community-based coalition development. In her role as Senior Director of Safe Choices, the youth and young adult-centered body of work at Safe Project, she invests her passion, lived experience, and professional skills to prevention strategies that focus on healthy development of individuals and communities. Rana's work is focused on building knowledge and effective school community collaborations for actions that bolster protections to prevent initiation and progression of substance use and mental health challenges while mitigating associated risks. Prior to coming to Safe Project, she was the first executive director of the Cambria County Drug Coalition, a coalition established in 2016 to tackle the opioid epidemic that was severely affecting the community. Rana began her career in youth substance prevention at Twin Lakes Drug and Alcohol Treatment Center. During her tenure, she advanced to the position of prevention coordinator, and in the last 6 years, she simultaneously served as the director of the Somerset County Drug-Free Communities Coalition. She is a graduate of Point Park University in Pittsburgh, a graduate of the Somerset County Chamber of Commerce Leadership Training Institute, and was recognized in 2020 by the Pennsylvania Business Central publication as an outstanding woman in business. Without further ado, Sydney and Rana.
Thanks, Leslie. Good afternoon, everyone. I too would like to welcome you all to this training. We sure are grateful that you've carved out some time to spend with us here. Sydney and I are doing a bookend presentation for a series of presentations that occurred throughout Recovery and Prevention Month. We're looking forward to the next 90 minutes together with you, confident that it's going to go really fast. And so with that, I'd like to begin by doing an overview of our webinar objectives for you. First, we'd like to engage you as participants in a guided reflection of prevention throughout the years. Have you gained an understanding of the 4 paradigms of the addiction and recovery model? From there, we'll identify ways in which the paradigm impacts prevention practices, programming, and services. We'll then invite you to take part in a paradigm exercise that includes response as well as reflection, and conclude then the session with considering applications of the paradigms for your multidisciplinary approach to prevention. One housekeeping tip is that we'd like to invite you to grab a piece of paper. You will need that later in the presentation. And if you could number that piece of paper 1 through 32. Okay, over to you, Sid.
Thanks, Rana. Hey friends, it's great to be with you here today. So you have already heard us use this word paradigm a couple of times. Before we jump in, we just want to lay the foundation of what do we mean by this? So think of a paradigm as a lens or a pair of glasses that we use in which to view the world. So a paradigm is a framework that contains our basic assumptions, our ways of thinking, our methodology that are commonly accepted by members of a community. It's also our cognitive framework, often shared by members of a similar group. It's our mental model for something. Our paradigms or our lens impact quite a few things in the way that we view the world. So they impact our how, which is our general attitudes and stances, our approach to which we see things as valid or not valid. They impact our what, so our actions and their associated outcomes. And lastly, they greatly impact our why, so our motivation and our end goals. So as you walk through this training with us today, I encourage you to kind of take off various paradigms, various lenses, and walk alongside us as we explain the 4 paradigms to you today. Back to you, Rana.
All right. So starting off with our first engaging exercise, a reminder, if you would so kindly, to go ahead and put your responses in the chat. We'll kind of follow along. But what we want you to do is to start by answering the question that's on the screen. And the question says, when you think of prevention, what is the first thing that comes to mind? Just pause for a moment, give you the opportunity again to type out your response in that chat to everyone. All right, you can see them coming in. So being proactive, educating the community, educating and understanding, awareness and advocacy, very similarly, saving unnecessary suffering, resources, preventing individuals from substance use, psychoeducation, educating youth, families, children, and the community, providing skills teaching. Chris says it's elusive. Super. So I'm going to let you keep going as I'm going to jump into the idea that most of us probably practice prevention or some form of prevention every day, right? And the answers are varying, and that's perfect. And I appreciate you sharing. Again, the first thing that comes to mind, that'll be your first time today of many to share with us. And the vast array of responses is likely due to a couple of things. One is that the prevention field is ever evolving. And I'm going to get into that in just a moment. And the other part of that, or kind of combined with that, is the fact that we understand the field of prevention in part or largely in part by the era with which we were first introduced to it. So if you would, come along with me through a little bit of prevention through the years, a little history lesson here. This slide in and of itself could be a 90-minute presentation. I promise you it won't be, but we are going to use this timeline as a way to lay the groundwork and prepare for the paradigms exercise that's coming later in the presentation, as we keep in mind throughout the entire presentation, the efforts to broaden the scope of prevention. So in the 30s, as you can see, self-explanatory there on the screen, this is an era of prohibition. In the 40s and 50s, then we come to a point where we're shifting out of prohibition and we're beginning to enter into the information movement that was speckled with some scare tactics. So lots happening during that time frame. In the 60s, we're then at an era, full-on scare tactics, where we believe that we can potentially scare people straight, and that We're providing, as well as some forms of scare tactic, entering into an information era where we're providing information and the idea that the more people know, that this knowledge in and of itself would change their attitudes, their beliefs, and their behaviors. What we learned is that studies from this era revealed to us that yes, people did indeed have an increase in knowledge level, and that in some cases, the scare tactics even had somewhat of a stunning. It might stun them, it might have them pause, but in the end, this strategy in and of itself did not produce measurable long-term results. Hence, then we move into another era of substance use prevention that involved a strategy based on values and decision-making. This idea of reducing substance use through personal advancements, through the development of self-esteem. Similarly to the scare tactics and the information-based approach, this value and decision-making model was largely ineffective in creating long-term and lasting change, especially when it was done in and of itself or in a siloed effect. We then enter into one of the most familiar errors in prevention in the 80s when we come into the Reagan administration in an era of just say no, as well as the start of drug-free school zones and nonprofits dedicated to the cause. The lessons that we learned from this error is that just saying no isn't just that easy, and that just saying no was based on pure risk. And this in and of itself does not resonate with the developing youth brain. Hence, then we move into another era of the 90s, which was an era or a decade of the brain. This decade also incorporated the utilization and the introduction of risk and protective factors, substance refusal or resistance skills, social development strategies and skill development, while simultaneously the introduction of kind of this systems process. This is where we started to hear about the impact of collaborations across systems and the engagement of multi-sector coalitions and community agencies. So we're now starting to think about this approach of more people coming together and more people elevating and working together on this topic. And indeed, we saw results from this era. And we continue then to take the best from each era into the next. And so where we are now is in an era based on science. Lots of emphasis on health promotion that demonstrates substance use prevention being placed in a comprehensive strategy. So it's no longer this idea, it's actual coming into applicability or into practice. The utilization of multiple risk and protective factors. So we're not just looking at some, but we're looking at it in all domains of the human life. So this includes self. This also includes home and family, school, community, as well as being supported by that community, being supported by policy and systems across the board. So simply stated, the shift from focusing solely on awareness, on fear, on consequences, to more of a science and medical model that's fully health promotion. So in summary of the whole timeline and the journey with which we've come, substance use is this ongoing process that aims to prevent initiation, progression of substance use while also mitigating the associated risks. We've learned a lot of things about the prevention strategies and prevention approaches throughout the years. It's clear that the prevention field continues to grow, that it continues to evolve, and that there's merit and value to prevention. What I'd like to do now is to go through a highlight of the basics, utilizing a who, what, when, where, why, and how approach, and setting the stage for the introduction of the 4 paradigms and the steps that we can take to broaden the lens of effective prevention. So to the basics, I also have to add a disclaimer here in that some of this might be a review, especially for those of you who are seasoned in the field. I'm hoping that there maybe is a nugget of new, but nonetheless, just want to throw that disclaimer out there. Come along with me if this is a review. And for those of you that are hearing this for the first time, we want to break it down in doable bite-sized pieces that are comprehensible so that you can have this for your toolbox after the training. So the first, the who, basically is everyone. In the era with which we are in, prevention involves everybody coming together, vested participation from all in the community who are fostering and building a culture of prevention, together elevating, prioritizing, teaching, and practicing prevention. We then move to the what. All right, there we go. What is the realization that prevention draws on many scientific fields? Prevention planners and practitioners are truly pressed to put into place solutions to urgent substance use problems facing individuals that live and reside in communities across this country. We know that prevention is best when it's not random. We know that it's best when it's not a blanket approach, one program for all, when it's not one and done, and lastly, when it's not based in fear and shame. Research and experience truly has shown that we must begin prevention by taking a mindful and dedicated look at what are the problems and why are these complex problems occurring. And only then can we begin to establish an effective prevention plan and tailor strategies that are designed for each unique community, thus rooting prevention in a multitude of sciences listed on the screen: behavioral science, life science, social sciences, public health science, as well as developmental sciences. On now to the when. When now is shifting from that drug talk. I can't even tell you through the years how many people have said, well, I've had that talk. One talk is not enough. We want to shift into a culture where there are many talks, where we develop our work over time and we continue it on an ongoing basis. In a recent report from NIDA, the National Institute on Drug Abuse, it was made increasingly clear, and this is so important, that the roots of addiction risk as well as resiliency are planted very early in an individual's life. So again, the importance of starting at a very young age and having reoccurring conversations at appropriate developmental levels. The when, from the when to the where. Where is basically everywhere, at home, at school, and in the community. Prevention isn't just a family-focused endeavor, nor should we believe that the schools have it covered. And in many ways, we know that that's not the case. The schools need us to come alongside of them. And that's why you see so many community efforts across our country and legislators investing funds in things like community coalition development. So the idea here, I also want to reiterate something that's not on the screen, and that is that this also includes the medical field, a pediatrician's office, and those who practice medicine, as well as in athletic and sports, in the faith-based community, in youth-serving sectors and clubs and organizations like YMCAs, Boys and Girls Clubs, and Scouting. And I'd be remiss if I didn't also add workplaces. So across the spectrum, prevention can be practiced in all parts and all facets of our lives. So why? Why do we do that? It's pretty simple, actually, because prevention saves lives. It's cost effective. And truly, the analogy that an ounce of prevention is worth a pound of cure resonates. Prevention has us shifting our mindsets from reactive to proactive. When we take proactive approaches and go upstream, these upstream supports then support those who are downstream, carrying less of a public health burden. And lastly, the how. So knowing all of this, how do we go about doing this? From a prevention basic lens, what we want to do is broaden our work, utilizing our head, our heart, and our hands. We do this through prioritization and practicing, as well as investing and making investments in prevention, making sure, again, that we're doing targeted and mindful efforts of analyzing communities through a data-driven process and evaluating our work, which will continue to have the field of prevention evolving so that we can take the best practices into the next generation. Doing so with care, compassion, and kindness, and this idea with our hands, all of us coming together for effective change. Doing this together, again, alleviates the burden on one specific sector and allows us to be more effective in a team and collaborative approach. And lastly, through a paradigm shift, where we shed light on rooted assumptions and beliefs that impact our prevention work, hopefully in the end, allowing us to be more effective in our work and to better understand the best practices for targeted communities. At this juncture, I'd like to go ahead and pass it back over to Sydney for that introduction to the paradigms.
You, Rana? Okay, friends, what I'm going to plop in the chat now is access to the Paradigms tool. So we had asked you previously to get out a piece of scrap paper and a pen. You are going to access the tool using this Google link. We're going to do so relatively quickly. So there are 32 questions on this survey. It should take you 10 seconds or less. Why is this? Because the tool is meant to uncover our general ways of operating, which honestly happen without much consideration, right? So you are going to find yourself answering questions either 0 of never agree, all the way up through 5 of I always agree, or this is very central to my approach, or somewhere in between. If you find yourself pausing on a question, that's okay. I think you'll find yourself doing that a couple of times. Just circle it, right? Don't take too long analyzing any sort of question. This is really supposed to be kind of our conscious and unconscious beliefs about various questions. If you finish early, go ahead and move on to the questions to consider. But I'm going to give you saying I'm finding it difficult to edit the form. That's actually intentional. So I don't want you to edit the form. I want you to use a piece of scrap paper and number it 1 through 32, and then put your 1 through 5 answer on each form, just because it gets a bit wonky if all 35 of us are trying to edit the same form. Friends, I've given you our 2-minute warning here. So keep working through, but we're going to move on soon enough. All right, friends, simply for the sake of time, let's move on. If you're not done with all the 32 questions, that's okay. Keep working through them. But remember, this is supposed to be kind of what are your initial thoughts about this question? What are some of our underlying beliefs? All right, so let's review the concept of a paradigm. So as you know, the lens in which we view concepts, the lens in which we view our world. What I want to note here is that each paradigm that we are going to review today, I want you to be thinking about what are the pros of viewing the prevention landscape, the prevention, harm reduction, recovery field through this lens. What are the cons of viewing our field through that same lens? And then where do you see it in your particular work? So I know y'all introduced yourselves in the chat, and some of y'all, we were able to glean you're working at a county health department in the area of prevention. Potentially you're an educator working in the field of prevention, right? So how does this apply to your work? And where do you see particularly each paradigm showing up in your work? Okay, let's jump in briefly by talking about how did this tool come to be. So all of us at Safe Project work to stop the addiction fatality epidemic, and we do that in a multitude of ways. But what we found is that the way that we do that really pertains to people's hows, people's whys, people's whats, right? And so the way that people are viewing the addiction epidemic looks very different. So we were trying to understand how are we all attempting to solve this epidemic, but we're going about it in very different ways, right? We're all taking different strategies. So why is that? And then ultimately, what are our end goals? And we realize that folks are doing this in a variety of different ways because they are viewing the addiction epidemic through a variety of lenses. All right, with that said, we're going to jump into our next interactive piece, and there's a lot more of this to come, so stay energized with me. The first question that I want you to consider, and please do put A, B, C, or D in the chat so we can all follow along, but if you had to categorize addiction as either A, a condition, B, a disease, C, a disorder, or D, all of the above, what would you classify addiction as? I'm seeing a couple come in here. Okay, lots of D's, quite a few A's. Yeah. Oh, I see a B in there. Love it. Okay. Friends, to make it even harder, if you couldn't classify it as D, all of the above, I encourage you to think about what would you classify it as then. But I see then if we exclude D, I'm seeing quite a few A's of condition and B's of disease. Yeah, so we can already see within our group here, all of us are coming at this through a slightly different lens, purely in thinking about what is addiction to us. To extrapolate on this question, I wonder if you think that everybody agrees, right? Everybody that you're working with agrees, all of your colleagues, do they agree? And has your answer to this question always been the same? Has your answer to this question expanded throughout your time working in this field? Okay, so before we start jumping into each of our paradigms, I want us to talk about and reflect on the fact that when we track our beliefs and our attitudes over time, we develop a structure in which we can reflect on the addiction and recovery movement and to find our role in it, to find our positionality in it. Ultimately, how we think about substance use matters. So let's jump into some of the ways in which we can think about substance use. Okay, first we're jumping into the moral paradigm. So some of the core tenets of the moral paradigm is that addiction and substance use is rooted in an individual's and or a group's moral failings, right? So these can be thought of as character defects, or maybe it's ignorance. Really the sentiment of if you knew better, you would do better, and ultimately you would be better. Also, under this moral lens view of thinking about addiction or substance use, we see recovery as taking responsibility and making amends, right? Really taking it personally. There's also a heavy focus on the individual and their role in the cause or conditions of their condition, alongside a focus on the impact that they might have on innocent bystanders, right? Often we see this, how are folks with an addiction impacting others? Potentially even more so than how we think about how is addiction impacting that with that as a lived experience. There's often this condemnation of bad influences, people that are experiencing that. And then really under this paradigm, ideally a society should have no addiction. I want to note here too that shame is often utilized as a behavior change motivator under the realm of moral paradigm thinking, right? So shame is used to enforce people to change their behavior. We can have a whole nother 5-part series of is shame an effective behavior change motivator? I would strongly argue that it is not a sustainable behavior change motivator, but that'll come a different day if you're interested. So I want us to reflect on the messages that we are using as prevention professionals, as parents, as teachers, as peers, in what messages are we using, and will this get us the end result that we want to achieve with young people or with adults that are using substances? So in what ways can we change our messaging to move away from scare tactics, right? And Rana did such a great job at kind of illustrating the history of how we have work to combat the addiction epidemic or substance use throughout our nation's history. But how can we move away from scare tactics and the morality of substance use at all, and more focus on education, on providing people with options, and then also understanding, which I was so thrilled to see so many of y'all are already using that lens as you're doing the work, as illustrated in our chat. So also noting here that many times parents think that school has prevention and alcohol and other drug education covered, when really, as Rana stated, prevention starts at home. And we don't really know what paradigm our schools or our communities are using. Parents are our children's leading protective factor. So schools should really reinforce messages that young people are getting at home. We can also see the way that punitive approaches have played out when it comes to substance use, right? Again, we can have a whole nother conversation about how the criminal justice system has influenced substance use disorder, how substance use disorder has impacted our criminal justice system. But where have these punitive measures gotten us? Where has viewing substance use disorder through a moral lens gotten us? And then when are we and how are we still using scare tactics today? Do we think it's as easy as just saying no? And as y'all know, it's not that easy. Okay, friends. So this is one I want to hear from you. Let's chat a bit. Again, feel free to throw in the chat here. What period in prevention history used more moral paradigm thinking? And then what are the ways that the moral paradigm is still entrenched in just say no messaging? What do y'all see? What are y'all hearing, whether that's in your community, in your workplace, or others? Ooh, I love it. Cal says prohibition was more moralistic. Very true, Cal. Thank you. Yeah, with that prevention in the 30s, the 40s, and the 50s with prohibition and bans, really as it pertained to use in the public eye, was a combination of bad influences. We also saw in the 70s, the information era and the value of decision making. These models aim to reduce substance use through knowledge and personal development with self-esteem strategies. Yeah, we're seeing a lot of timelines here. The 1980s, coloring books that were titled Be Smart, Don't Do Drugs. Angela, thank you. Welcome to being here, fellow. And the period of the 1980s, I'm seeing a lot of 1980s here. Absolutely. Yeah, I think that timeline was really helpful in this. So I wonder how we can be more clear with folks in general, and especially youth, that choosing not to use substances is not about being morally superior, right? There was a lot of messaging like this, even when I was in school in the 90s, about in what ways was the DARE program entrenched in I am better than you because I choose not to do that, right? I'm seeing here inpatient treatment was big in the 1980s. It was almost fashionable. I think in many ways, intentionally or not, morality is a central feature in prevention and recovery work. Yeah, my first grader came home with a Say No to Drugs bracelet yesterday. Wow, okay, so there's still ways in which this is alive and well today. So again, how can we be more clear with young people, with all people as a whole, that choosing not to use substances or addiction has nothing to do with our morals and particularly with being morally superior. As we also know, just saying no is not that easy. And also this message often doesn't appeal to youth, in that the youth brain is not always risk adverse, right? There is this developmental stage of kind of testing and understanding what risk is. And for a young brain, it's not necessarily as adverse to risk as we might be more we develop. Also, how can we help youth rather than making them feel worse, right? So when we attach someone's morals or someone's character to the choices that they make, someone feel worse. And again, we can have a whole conversation about what does shame do to behavior change, but what does punishment do? And how does it make a person feel, particularly our young people, how does it make them feel when they need to make a behavior change? Is that empowering them to make a behavior change, or is it using shame as a way to either increase their likelihood of making a behavior change or not? Okay, let's move on here then, friends. So what I want you to do now is add up your scores to this moral paradigm. So you'll see from the tool, each of your questions is numbered. I want you to go through and find those numbers that are on the screen here and then tally up that number. So questions 1, 7, 12, 13, 18, 23, 24, 27. You'll tally all of those numbers up and you will get a number out of 40. So I'll give you just a second here to do that math. All right, friends. So we should have our number here for the moral paradigm, but not to worry, we still have 3 paradigms left to go. Oh, friends, thank you so much for sharing your scores. If you feel comfortable, you certainly do not have to if you don't want to, but I'm seeing a lot of folks plopping in the chat the way in which they scored out of 40 on the moral paradigm. Thank you so much, friends. I'm excited and eager for the discussions that will come out of this. Okay, friends, let's shift into talking about the disease paradigm. So through this disease lens, our core tenets is that addiction is caused by a physical, a mental, or a genetic deficiency or some sort of an abnormality. So under this, people with substance use disorder are physically or chemically impaired. You often hear this in various recovery movements, right? I have a chemical imbalance. Whether the research actually suggests that or not is, again, a conversation for a different day. And there is this focus on curing the problem or alleviating the symptoms or managing this chronic issue. So under this kind of philosophy, addiction as a pathology, we can test it, we can identify it, and we can treat it, right? It is a disease. With this, addiction and recovery are understood through the perspectives of those that have a medical or a clinical expertise. We can really see this in response to the moral paradigm, in that a natural shift after the moral paradigm was addiction is a disease, it is not a moral failing. So again, in response to this moral paradigm, the paradigm of disease has been valuable for a progress such as insurance coverage, such as the growth of the treatment industry, and as we have approached destigmatizing addiction, right? So kind of a natural shift away from the moral paradigm way of thinking and into this disease paradigm way of thinking. I want to get hearing from y'all. In what period of the prevention history have we used more disease thinking? Friends, I can bear with me because it's going to be a bit clunky, but let me go back to our timeline here. So what part of our history and our prevention history have we seen more disease paradigms way of thinking? Yeah, I see the 2000s. I'm going to come back to the start. Sorry, friends, this is clunky. Okay. So yeah, continue to put in the chat here what period do we see more of this disease thinking, and then how does this disease paradigm not allow for growth or behavior change? What are your thoughts on that? I'm seeing a lot of 1990s and 2000s. Yeah, definitely. Absolutely. Dalton, okay, yeah, the use of medications over therapy. I think that's true in a lot of aspects in our medical model today, right? Whether that's with substance use disorder or other coexisting mental health conditions. So how does the disease paradigm not allow for growth or behavior change? Yeah, I'm seeing a lot of pharmacology under the medical model. Yeah. Friends, do continue to give me your thoughts in the chat. Oh, okay, I'm seeing an idea of scapegoats or self-medication. I think in the early 2000s, we saw a major shift in the disease paradigm in formal treatment settings, although mutual aid has been doing a version of this since its inception. Yeah, so we can kind of see what ways in which the disease paradigm is kind of pervasive along options, right? So whether that's in kind of a formal treatment option, whether that's in our mutual aid groups, like one example might be a 12-step meeting. What are the ways in which we hear clinicians or our peers using this medical terminology and thinking of their condition or others' conditions through that of a disease lens? I'm seeing here reliance on pharmacological interventions in lieu of a holistic approach. Yeah. Okay, so as y'all noted, we can see this a lot in the prevention era of the 1990s and the 2000s, right? So this era in which we begin to understand the brain as well as the scientific medical model. I want us to think about, though, what does this mean for families in which addiction runs, right? So if we talk about, you often hear addiction as a family disease. I know I heard that a lot growing up for a couple of reasons. One, right, in that we see that there is a genetic component to addiction, not always, but there can be. And also, addiction does not just impact the person that has it as a personal lived experience, it impacts everybody in the family. But what does this mean for families in which addiction runs? So when we're seeing intergenerational use, does this encourage people to know that it doesn't have to be a part of their lived experience, right? When we talk about addiction as a disease, and a disease can be passed down, do people still know that they have they have agency in disease onset, right? And again, friends, we could have an entire conversation about epigenetics, but I would honestly love to have, but again, a conversation for another day. So sometimes a person could be in recovery, but not feel as though their recovery is something to celebrate because they're opting into having a disease, right? So through putting yourself into this bucket of, oh, I have the disease of addiction, what does that mean? You're opting into having a disease. And then what does this mean for different recovery pathways? The idea that you can only be in recovery with full abstinence. I would also argue that when we turn this into a disease, when we turn it into the medical model, are people as aware that it is something that they can fully recover from, right? And this is, again, a topic that we can discuss over many, many book clubs for the rest of our lives. But right, if we subscribe that addiction is a disease, is that disease then chronic, or through behavior change, through holistic well-being and holistic healing, can we change our circumstances and can we fully recover from that disease? Does a disease paradigm allow for the freedom to do that? Or will we forever be stuck in, I struggle or I experience the disease of addiction? I really encourage y'all to noodle on this and think about in what ways does it influence our way of thinking? In what ways does it influence our community's way of thinking? And then what might another option be? Okay, friends, let's do another bit of math here. So we are going to add up our disease paradigm. So numbers 2, 6, 11, 14, 17, 20, 21, 29. Add all of those numbers up. And again, you will get a number out of 40. So I'll give you just a second to tally here. Oh, I'm seeing so many CRLA fellows here. Thanks for being here, y'all. Yes, friends, if you're comfortable, please do continue to put your scores in the chat if that is something you're interested in. No pressure to do so, though, if you would not like to. But I'm seeing a couple here. I think our picture will become a little bit more clear the more we know our 4 paradigms. We can already see many of us will have 1 dominant paradigm. A handful of us will have 2 dominant paradigms. So something to think about. Yeah. All right, friends, just for the sake of time, let's move on and let's start reflecting on our 4th paradigm, which is that of the social paradigm. So some of the core tenets of the social paradigm are that environmental factors are what create substance use disorder. They do this through a couple of ways. So first, it is developing conditions for coping or escaping, right? So it is our environment that creates our need to escape, and we do that through substances. Also through enforcing the norms and the expectations. So what use is acceptable versus what use isn't. Under this paradigm, also, substance use disorders are enforced through prejudice, through stereotypes, and through discrimination. It is really therefore these inflexible policies and procedures that create barriers to inclusion and pragmatic approaches to support. Also, under the social paradigm, substance use disorder is more indicative of problems in our society than of individuals, right? So we saw here that under the moral paradigm way of thinking, someone that experiences substance use disorder, that blame, so to speak, falls on that of the individual, versus the social paradigm is more substance use disorder occurring in our society is more indicative of societal problems. And then therefore, whose responsibility is societal problems to solve? Well, it's our society. Under this paradigm as well, substance use disorder is culturally defined, and it is very much intertwined with questions of diversity and inclusion, right? So the way that we might define a substance use disorder, potentially often through the DSM-5 in the United States, might look very different than how it is culturally defined in India, right? Or how it is culturally defined in Italy, in which our society has very different kind of societal roles of alcohol, other drugs, et cetera. Okay, under this social paradigm, we see a lot of person-first language, right? Where the social paradigm is most visible in this language. So a person with a substance use disorder. It also is this, it's a reaction to and the dismantling of stigma that is therefore the focus under this social paradigm. So again, we know that society influences our work, and we can promote positive behavior changes through empowerment than through stigma. Again, this is on all of us as part of our society. If we have a social norm that everybody drinks, right? If this is coming to us from a societal level, this impacts our social perception, and we are ultimately products of our environment. Also, we can certainly talk about how the marketing exists in this space. So alcohol or cannabis marketing makes us think that overusing is not okay unless we're in certain situations, right? So I've spent many years on college campuses, either as a student or working, and students often get the messaging from administrators or health promotion professionals like, hey, be mindful of how much you're drinking. And then they see a billboard with the school's basketball team and it's a Budweiser billboard, right? Or drinking is glorified in particular environments such as football or tailgating, right? So to what extent does our society play a role in this? And if we are telling people, hey, don't do that, or just say no, are we also offering them alternative choices? Especially when we live in this culture. We live in this culture in which we are both to go back to the social paradigm where folks are increasingly needing to escape from the human condition. And we're telling folks, hey, don't use that to escape, but we're not providing them alternative ways to cope with their lived experience. So youth substance use rates are declining, and potentially we can contribute this to the social paradigm. Yes, we need education, but when we move away from what is historically done, we can increase support, particularly using a paradigm shift. So I'm going to jump here to our Let's Chat. Friends, what period of prevention history have we used more social paradigm thinking? I also want to note here, Rebecca put in the chat, the disease paradigm allowed for a lot of innovation in regards to medication-assisted treatment, which is so true. And that was such a great aspect. And she notes here that if people believe that their brains and or their bodies can't recover, and that they have to live in this disease state forever, does that change how we engage in doing the work of our healing? Yes, thank you for noting that, Rebecca. So I'm seeing here some 2000s, mid 2000s. Yes. All right, friends. So I want us to think about here. I'm seeing another most recent with Recovery Capital. Ooh, Isabel, thank you for noting Recovery Capital here. Absolutely. Right. So what are the ways in which we allow our recovery to thrive? And really just what are the ways that we bolster our holistic well-being? Often when you ask folks like, what does recovery mean to you, or what do you do for your recovery? It might be for some folks, I go to a recovery meeting. For other folks, it might be, I go for a walk, I go for a hike, I eat foods that nourish me in a good way. I talk to my loved ones, right? So just thinking about our holistic well-being and thinking about holistically coping or healing from that is the human experience that all of us are impacted by. Okay, so with this approach, I want us to think, are we coupling our education and our positive social norming messages? So instead of scare tactics, this idea of developing healthy coping strategies instead of substance use is a growing theme, right? And we're starting to see this more with young people, particularly in, I can't speak to a lot of the field, but particularly within higher education, right? There is this real focus with young people, with emerging adults of what are you doing to cope? And if you take out this way that you have been conditioned to cope through cannabis, through alcohol, what are other ways in which you can do that? Okay, Cal is noting here that the social paradigm using health promotion and employer and union sponsored health benefit plans in the 2000s. Ooh, Cal, thank you so much for bringing that up really and showing us the intersectionality and how does this show up with adults in the workplace? Okay, friends, let's understand where we fall on the social paradigm. So again, I'm going to give us a couple minutes here. You're going to add up your scores to the social paradigm. And again, that will give you a number out of 40. Okay, so potentially I'm seeing a couple more numbers come in. Potentially our dominant lens might be becoming a little bit more clear, but we still have one more to get through. So let's see how we fall after our fourth paradigm. And our fourth paradigm is that of identity. So the core tenets under this identity paradigm is that the relationship that an individual has with substance use is complex and it's often very diverse. So labels serve to develop somewhat arbitrary groups that can more be accurately understood as spectrums, right? We know that substance use disorder falls along a spectrum. And substance use is not inherently pathological or negative or tragic or unhealthy. Instead, it can be valuable when truly understood. Stigma about people who use drugs is really what causes the most harm. And we need to listen to people with a relationship to addiction or substance use, those that have lived experience, to understand what well-being looks like for them. Through this, the empowerment of a positive self-identity and agency is the focus, right? Autonomy, personal empowerment, etc. All right, so a couple things I want to note here. When we put people into boxes of someone that struggles with a substance use disorder or not, or a family that struggles with a substance use disorder, we might hear messages of, oh, that poor kid lost their parent to an overdose. That poor kid heard that human heard that, and it reinforces that substance use is inherently pathological or tragic. It is also highly stigmatizing. So when we identify people into groups as problematic or people as those that we should feel sorry for, rather than realizing that people are much more than their experiences, and again, that substance use disorder and alcohol and drug use in general is complex, and no two people might use for the same reason, right? I also want to note here that, do young people identify as in recovery, or do they feel that they need to hide it? Do they feel that their recovery, that part of their identity, is something to be celebrated? What happens when we tell someone that is in recovery that instead of being celebrated, it should be shamed, right? And we often talk at SAFE about the stigma that we often feel towards people in recovery is the stigma that is exhibited towards people that use drugs, right? Okay. Thank you so much for talking about lived experience. Agree with Melissa on the power of lived experience. Yes, totally. And we can very much see the difference in the paradigms in who are we listening to, right? Or whose opinions do we kind of defer to, right? Under the disease model, that might be more of researchers or clinicians. Under the social model or the identity model, it might say, hey, let's listen to the people that have this as a lived experience, and particularly those that have been most marginalized by that aspect of their lived experience. Okay, friends, I want to hear from you. Let's chat. What period in prevention history has used more identity paradigm thinking? And then what can education in schools do to prevent substance use and stigma? I'm sure many of y'all know this very deeply in working in schools. All right, so where have we seen this most in our history? Well, potentially in the prevention era, right? So the 2000s, the today's, in this scientific and more comprehensive, holistic health approach, as many of y'all have noted in the chat. Also, with substance use education and prevention in our schools, whose voices are we hearing? And what is their approach, right? So this kind of speaks to what we've been seeing a lot of in the chat. I used to work in higher education for many years, and something that folks would always come to me and ask for an internship or ask for a job, and they would say, I am best qualified for this position because I have never used alcohol and other drugs in my life. And I'm thinking to myself, that makes you the least qualified for this position, right? Because if you don't have this as an experience, if you don't know why another student might be called to use substances either to cope or to do better or to feel better, then what help can you be through a peer lens? Okay, so I see a couple, lots of things here in the chat. Some folks say in 2000s in education on the effects of substances, letting them know it's okay to not be okay and that there is help out. Yes, I love that. I think that we are just starting to scratch the surface with identity and social paradigms being centered in our efforts, especially with youth. Rebecca, I would totally agree with that. Stigma training with teachers and students, have presenters that are in recovery. Angela, so true. Let's see, late comment from a previous slide. I found recovery when I was 20, and so much of the shame and stigma to me came from the recovery community, which questioned my experience. I think it's important to recognize that experience is truly individualized and should be. Absolutely, friends. We've got a presentation here on kind of the multiple pathways of recovery, but so often, and you hear this sometimes in the recovery movement, but some of the most judgment you feel as a person in recovery comes from your own recovery circle, right? Because everybody that feels like their life has been changed, you want to scream from the rooftops, this helped me. And it takes an extra step of reflection to recognize that what helps me might not help you or someone else, because my cause and conditions were different from somebody else's. Yeah. because laugh out loud to someone saying they're best qualified because they've never used, right? But that is kind of what has been touted throughout history. And for these college students, they grew up in a time of the just say no approach. And so they think I'm looking for someone that has just said no their whole life. And there's certainly value in that. And when we look at this peer approach, which many of our touched on, we need a peer that understands, and often that understanding comes from lived experience. So I see here educating students and their families about the dangers of drug use and how to prevent misuse and addiction. So some of this potentially reality-based education, and also some of those alternative options, right? Not just the, hey, drugs are dangerous, don't use them, but hey, potentially you're looking to cannabis as a way to cope after a long day. What are other ways that are going to work for this individual that are also ways to cope after a long day? We have to provide alternative options. Cultural consideration is needed to be prioritized as we imagine new approaches and solutions. Rebecca, thank you so much. What would be helpful for me in the way that I grew up in my cultural perspectives is going to look very different than someone that grew up through a different culture, through a different nationality, through a different religion, right? And what does that lens through their culture say about substance use? Recovery journey reflects individual choices leading to self-discovery and self-actualization. Absolutely. Okay, friends, so a couple things here is that I just want to go back to comparing this to our moral paradigm approach. So are we using just say no approaches because it's easier? Are we using it to check a box? As someone who did behavior change work for many years, it is always easier to tell a young person, to tell a college student, to tell anyone, hey, just don't do that. That is the easiest thing that we can possibly do. It takes a lot more work to talk to young people about what are they experiencing? What are their thoughts, beliefs? How are they coping? And what are their options? What are their other options? Also, noting here, overdose prevention in schools is a very important step, giving tools for education and giving evidence-based responses. So as many of y'all have noted here, what does a holistic approach to this look like? How can we approach students' mental and emotional well-being and the way that that contributes to substance use? How can we do overdose prevention, naloxone training, fentanyl testing strips very well? How can we also provide alternative options for students? How can we destigmatize? Yeah. Okay, we need to provide other training. I'm seeing in the chat here, trainings that people can use to replace, but we need to check to make sure that it is not something that becomes addictive also. Yeah, Angela, very interesting, very important there too, right? So if we're providing alternative options, what are these alternative options? Is it something else that people can use to escape, right? I used to work with college students that are, I used to drink 5 standard drinks every night to cope, and I've switched to cannabis because it's a healthier option. Well, cannabis, healthy in what way, right? Are there other options that might be easier than cannabis? Because anything can be psychologically addictive if we are using it to escape. Okay, let's move on then here, friends, to quantifying our identity paradigm. So you're going to add up the numbers that you see on the screen here, and that is for the last time going to give you your number out of 40 for the identity paradigm. Y'all are getting quick with this math, or maybe you just already did the math. I love that. All right. I'm seeing a couple here. Yeah, we have quite a few diverse main paradigms. Some of y'all are falling at an intersection of many different paradigms. So I find this next tool particularly helpful with that. Sorry, friends, I'm going to give us just one more second here in case you're still reflecting. But really, it should be whatever is left on your tallies is what you're adding up for the identity paradigm. And let's then draw our unique paradigm. So it is very unlikely that anybody scored a 0 out of 40 or even a 40 out of 40 on any of the paradigms. So while some of us have a dominant paradigm, which many of us likely will, or 2 dominant paradigms, our personal approach often includes all of them and very much the contradictions between them. So when we move away from our deep-rooted beliefs and the way that it's always been done, we can increase support and experience a paradigm shift, which often broadens our lens. So friends, I'm going to give you just a second here to draw your unique paradigm. This was very helpful for me in understanding, it's not, I have, I think, 2 dominant paradigms in which I view this addiction epidemic, and that allows me to do my work through a variety of ways to best meet the need of whoever it is that we're trying to meet the need of. Okay, friends, this is the most fun part of the day in which we really want to hear from you. So Rana and I are going to engage with y'all in the chat here. First things first, I'm curious, what are your initial thoughts and reactions to the results of your inventory and ultimately to the inventory experience as a whole? Was there anything that was surprising to you? Did the results of your dominant or couple dominant paradigms, was that surprising to you? What'd you think about the survey? Friends, I'm going to let you keep noodling on that while we also, oh, I got one. Yay. All right. Isabel here says, honoring folks that have different views, beliefs, and experiences about substance use disorder is an important step in challenging stigma. Absolutely, Isabel, right? So can we be more inclusive of everybody in our community and however it is that they choose to do what they decided is best for themselves? Yeah,
as a person in, I'm just going to jump in here and add that as a person who has dedicated 20 plus years of experience to the prevention field, right? So this is essentially what I call my chosen field, and I love it. And the fact that it's continuing to evolve and grow is a beautiful thing. But I have to tell you, and so for those of you who are here today, who are also practicing prevention, or prevention is your chosen career field, the light bulb moment that I had the first time that I took this, right? So in 20 plus years of experience, nobody had ever offered this. And so it's revolutionary and really it opens your eyes to all of the different paths or processes and the different audiences with which you're working. So whether it was through coalition work and the individuals that were coming to the table from the community, from law enforcement, from healthcare, from treatment and recovery, to then shifting into school districts and working with large schools, small schools, working with schools that were in affluent communities and those that were in really communities stricken by poverty. The idea that we can be better in our career when we carry this knowledge with us and when we really have an understanding where we're coming into it, as well as where others might be. So I just really felt a burning desire to share that right here. I think it's super important, and hopefully folks are having this light bulb moment of I can really use this and I'm seeing things a little bit differently than I ever have before.
Yes, Rana, I'm sure you'll actually have a lot to show us about this next paradigm or this next question, particularly being a prevention professional for so long. So when we think about our personal paradigm, friends, how does that compare to the expectations and the norms of youth and their communities? So where have we noticed the most tension? Ooh, a couple of folks have put their reflections from the paradigm tool in the chat. So Amanda says, mine was closely equal and only identity was a little higher by 10 points. All others were only a few points apart. This gave me good insight in areas that include all aspects of the view to benefit each individual person. Yeah. Caroline says, mine was not surprising at all. My tallies were all very close. I feel getting the information out there and giving other options will help individuals, especially youth, as they reach out for help in every situation is different. And that is something that can work for everyone. Yeah. Michelle is saying that social and identity, oh my God, too many stats. We're at the other end of the scale from moral and disease. I believe that there needs to be a shift from morality and medical models to more individualized social environments and self-identity. Yeah, Michelle, I love this. Rebecca says, I love being able to better understand where my thoughts, beliefs, and attitudes about this work are rooted. This kind of reflection is helping me identify where I still need to grow in order to be more effective in my career. Yes, Rebecca, absolutely. I think very similar for me, like I can identify the ways in which I have consciously or unconsciously learned and then viewed the world through different paradigms and where that is still exhibited today, whether that's the moral, the disease, the identity, the social, and then where do I want to go and how do I need to kind of hold space for understanding all of them. Maybe I choose to use one approach more so than others in my work, but how can I understand all of them so I can best serve individuals if, you know, know people in recovery that choose the moral paradigm as the paradigm for them, right? And so working with those folks, if that is the paradigm that they choose to view their lens, and also introducing them to other paradigms. But I'm curious, Rana, your thoughts and then other folks' thoughts on how do you think your personal paradigms compare to the norms of youth in their communities? And then, yeah, Rana, what do you think about that?
Yeah, and so I think that this is, again, incredibly enlightening. So many of the examples that were given in the chat, I can resonate with throughout the journey with which I worked. So very early on in my career, working at a youth drug and alcohol treatment center, I can tell you that young people who were in that center were carrying heavily with them stigma and shame. The idea that how can I be so young? How can I be here? A lot of this shame came from all of the different ways with which we carry stigma and shame, or the roots of with which it comes from. But unfortunate, I believe then it becomes a self-fulfilling prophecy, and that they start to believe that I have this disease, or that this will be with me forever, or that this is what happened in my family and everybody expected this of me. Shifting from then a treatment center, and yeah, it took a lot of work to build hope and to change that norm. I also want to give an example from working with school districts, and the idea of going into the school, and the notion that, some schools still have very rigid no use policies. And so there were so many times where I would be working with youth in alternative schools, or working with youth who were in long-term suspension programs, who had a substance use infraction, and were essentially being kicked out, and being told that they didn't necessarily belong here. And I think that this was really hard for them in an environment that was built for them to thrive and grow in. So what were the underlying root causes? That was something that needed to be explored. And so there were many times that I didn't gain bonus points when working with schools, but really felt the need and the desire to be honest with the idea that we make less progress when we hammer them with punishment, or hammer individuals with punishment. And instead, we really need to have this broader approach, this health-centered approach, this approach that recognizes each individual for their unique qualities. So we got to take this strength-based approach and instill hope and perseverance. So that's some input there.
Friends, I also see so many great ideas in the chat. I'm going to get to those in just a second, but I want us to reflect on here then. How do you think your personal paradigms compare to expectations and norms with other prevention professionals? Where do you notice the most tension? I also want to shift in, just for the sake of time, to digging into a few of our most controversial questions. So do please continue to tell us, how does your personal paradigm compare to expectations and norms with other professionals that you're working with? Particularly, where do you notice the most tension? But I want us to reflect here too on a couple of our most controversial questions. And I want to be mindful that we only have 15 more minutes. We could really done this for a whole day. So for each of these, I want you to think about, what did you put as your score to this question? What drew you to your answer? Where may you interact with this idea or concern in your organization? And what could the implications of this approach be? Okay, so first question here. Recovery is a process of redemption and becoming a better person. What did you think about this question? What paradigm? Well, actually, you can tell what paradigm this might fall under. Friends, I am loving seeing in the chat a couple of things here, right? So Michelle's talking about patterns of behavior which are culturally based. So important there. I also saw our friend Yemi talk about how, through the use of collaboration, we can better understand different paradigms and those that might be using different paradigms. Oh my God, there's so many things in the chat here. Angela, I love your point of tension arrives at stigma and shame. So not just for the person in recovery, but for their loved ones, their caregivers of the person in recovery. Absolutely. Okay, so Amanda's answering this question and saying that to me, this question is saying that a person is bad if they choose to use substances, not that they are exhibiting a negative behavior. Yeah, right. So this obviously we can see it comes from the moral paradigm in that it's not talking about our disease. It's not talking about changing our circumstances. It's saying that to be in recovery is to redeem myself and to become a better person. Now, I do want to note that many folks in recovery talk about how to be in recovery is to be the best version of themselves or to be your favorite version of yourself. So even kind of a subtle shift in our language can very much change the way that we're thinking about this. Okay. For the sake of time, let's think about another controversial question. What do y'all think about this one? So our focus on alcohol and other drugs often serves as a barrier to addressing underlying needs. Do you agree with this? Do you disagree with this? Actually, Rana and I got the privilege of chatting a lot about all of these things that we're very passionate about throughout this process. And we had a long conversation about kind of the upstream versus downstream approach, in that upstream approaches are, I would argue, have better outcomes, and yet they are harder, they're more expensive, right? So when we focus on alcohol and other drugs serving as a barrier to our underlying needs, when we think about young people in particular, it is much harder to teach our young people how to cope in this ever-changing world. And in this world where a lot of us adults are having a challenging time coping, right? When we also think about privilege and we think about the system, some of us have access to healthy coping strategies or therapy, et cetera, more so than others of us do, right? So it is so much easier to tell someone, just say no, than it is to tell someone, hey, this world is really scary or this world is really hard. And let's find you a resource and a community that can help you along with that. But truly, the argument is to work on addressing these underlying needs that might lead people to coping in such a way, et cetera. Yeah. Oh, Isabel, thank you for noting here ACEs. So adverse childhood experiences. Absolutely. Thank you, Amanda. Underlying needs is the root cause. And Angela saying, agree. This is where I believe the self-medication comes in. Yeah. Right. And a lot of folks with lived experience of recovery will say the same thing, or something different, right? Because we're all very different. But for many folks, it is so much more about life and what's going on the inside or the outside than it is about the drugs or the alcohol or whatever it might be. Rana, any thoughts on this one, or just the conversations that we've been having over the past couple weeks?
Yeah, so I feel like this ties right in with what I was just saying, and the idea of instead of kicking youth out or instead of making them feel like they don't belong, we need to be taking a different approach. The other part of this is, and I might get into this a little bit in the end if we have time, and that is this idea of promoting recovery in all of its forms, right? And so the idea that instead of saying, oh, this child's in recovery, or making them feel like recovery is a bad place to be, we're going to shine light and celebrate on the fact that this person is achieving recovery for themselves. And so I think that that's also something that comes to mind when I look at this. I think it's super important when we talk about coping, but the idea of recovery is possible, and that there are many people who are living absolutely beautiful, beautiful lives, and identify as being in recovery. And so we got to celebrate that and bring light upon that, which is something that has been done. And then I guess the last thing I would add here too is, very briefly, you mentioned the efforts of taking overdose prevention and elevating overdose prevention and the services and the things that we know work. Yet there are lots of barriers. And I think a lot of the barriers come from one of these paradigms in relation to naloxone or Narcan availability for young people. And so would want to work on that as well.
Yeah. Okay, friends, we're crunched for time. So I'm just going to show us our next two controversial statements. I want you to noodle on them a little bit. But the first one being abstinence is an important first step in overcoming addiction, right? So I just want to plug here that this is an example of bridging prevention and recovery. So these two concepts are not different, or not as different as we think. In fact, they often can work together in tandem. Also, can we hold space for different cultural perspectives of recovery, different lived experience, and understanding that for some folks, abstinence is absolutely something that they want for themselves and is very necessary for their recovery. Other folks, that is not a necessary step at all or a necessary first step, right? So can we be more inclusive in what we are thinking about when we are thinking about healing? Next, I want you to think about the question of if individuals knew more about substances, their use would decrease. So we all agreed at the beginning of the presentation that education is absolutely crucial in prevention, which it is, but it's unrealistic to think that someone can translate for themselves education into behavior change, right? There is an entire field of study in behavior change, and education is certainly a component of that. But just because somebody knows that what a standard drink size is, or the way that drugs are impacting their central nervous system or long-term health outcomes, that doesn't necessarily do anything for their ability to make a change, right? Behavior change is very complex, and it needs a lot more than just education. All right, friends, simply for the sake of time, I'm going to let you just reflect here on 5 sentiments in our work that folks have agreed with the most. So folks can agree that person-first language is useful and it helps us center the humanity of an individual over their diagnosis. Stigma is one of the most harmful aspects of substance use disorder. Recovery pathways should be unique and tailored to each individual on their own terms, right? We have to highlight autonomy as it pertains to recovery. Addiction must be viewed in relation to coexisting mental health conditions and their traumas, and approaches to treating addiction should be developed in ways that center the perspective of those with lived experience. Okay, so what do folks disagree with the most? Well, that it is crucial that our communities, our workplaces, our schools not tolerate individuals or groups that use drugs. Absolutely. That abstinence is an important first step to overcoming addiction, that in an individual knew more, they would do better or their use would decrease. Folks disagreed with that they maintain a level of skepticism about someone once they learn that they have used drugs, and then one day we will discover a cure for addiction. So we can already see in which we have shifted away. Thinking about that timeline that Rana illustrated for us, like we are at such a different place in that timeline than we were 60, 40, 20 years ago. And I think there's a lot of excitement for where we can go. Rana, I'm going to pass it over to you to talk about broadening our lens.
Right on. So we're on the homeward stretch, right? We're almost to the end. I promised you that 90 minutes would go fast. Here we are. And so the overarching theme, and the thing that I think that you would hopefully heard us say over and over again, is this idea of broadening the lens of effective prevention. And how can we do that? Utilizing the 4 paradigms and the understanding of the nature of each. There's a lot of things that we can do. I'm going to plant some seeds in your head for things to think about, again, in the interest of time. Also want to open up the door for you to reach out and to have elevated conversations with us on this topic. And so Safe Project will be, as Prevention Month comes to a close, we'll be practicing prevention throughout all months of the year, and we'll be planning some upcoming prevention roundtable discussions. So that's, again, an open invitation for you to come back with us to continue these conversations and allow us to be a part or a collaborator in, again, that multi-system approach to your work in the field of prevention. One of the things I really hope that you can take away with you, we're going to get to key takeaways, but when it comes to utilizing the paradigms in prevention, is to expand the way in which we deliver prevention to young people, to think about it no longer just placing their heads full of information or the belief that youth are vessels to be filled, but instead inviting and engaging youth in. Safe Project has an actual youth voice council. We have young people that come to the table that are engaged in our work as volunteers, and it's a beautiful thing. And so we certainly have some experience in that field. We endorse it and promote the inclusion of youth and of elevating the way with which we deliver prevention programs. In addition to that, we want to think about or be cognizant of the content of these programs. Remember, I said several times to you today that blanket programming truly is not effective. And maybe many of us have had that form of prevention in the past where it was one program and we all got it. And so this blanket approach isn't necessarily the best investment of time and energy and limited resources. And so that we want to have tailor-made programs specifically for communities, and the content that's being delivered should be appropriate for that audience. Modifying how we're delivering it, so kind of moving away from those scare tactics or that blaming and shaming, and again, taking that personalized, person-centered approach, and realizing that practicing prevention is ongoing, and that one and done isn't going to cut it. So that one conversation just really isn't enough. I need to reiterate something I just said a minute ago, and that is the inclusion of harm reduction efforts with young people in schools, on school campuses, and any environment where youth are involved. It's a truly vital and life-saving step that we must continue. So those are some things I'm going to offer. I'm going to move on. We have 2 more slides to go. Want to invite you to come with us as we share with you some takeaways. So the idea that, oh, this is Sydney, sorry, go.
Are you kidding me?
We label the slides on purpose. It's not to the end that we mess up the sequence, but nonetheless, our key takeaways, the things we want you to take in addition to what we just shared throughout the entire thing. We surely hope it was enlightening for you. But self-awareness leads to greater intentionality. And so just knowing how you're coming into this work, how you're looking at this from a personal perspective as well as a professional perspective, can allow us to all be more effective in our work. And there's some ideas listed here on the screen on how you can do that. And then the last is just, hey, happy Prevention Month. It is Prevention Month. We do have a website landing page loaded and packed full of resources and a full team that's looking at prevention and comprehensive prevention across the scope. Again, we invite you to be our partners in this amazing and wonderful work.
Friends, last thing, if you'll put in the chat for us too here, if you enjoyed this training today, what else do you want to learn? If we were going to provide another webinar, what would you want to reflect with us on? Passing it to you, Leslie.
Thank you all so much. We appreciate you. You can see here is our website. And again, as Sydney and Rana indicated, if you have any suggestions for us for content you'd love for us to cover, please feel free to put that in the chat, or you can contact us through our Safe Project website. Sydney and Rana, thank you again for your presentation today. A reminder to everyone, an email will go out with a recording of today's presentation, as well as the slide deck. All right, everyone.
Thanks, everyone.
Thank you so much. Have a great day. Bye.